Hi, I'm Dr. Kaushik. I'm a consultant pediatric surgeon at Manipal Hospital, Sarjapur Road. At this point, I would just want to pause this presentation and I would want you all to recollect the last statement I made. So, I am so and so at Manipal Hospital. What was that so and so? How many of you felt that I am a pediatrician? And if I was not a pediatrician, then what was the correct word? Well, this is what happens most of the times. I'm sure many of you, at least in your mind, would have concluded that he's a pediatrician. This is a misconception even among the educated, where many people don't even know that a department called pediatric surgery exists, or even if they know, they may not be knowing the full range of cases that we manage. So today my topic is titled as One Among the Many. So one among the many is because I'm going to talk about this department, which is one among the many departments, but often not highlighted, just like women feel that though they are in the population, many a times they are not highlighted. And this talk was on occasion of Women's Day at Quest Global. So everyone knows about male ego, and many surgeons are quite confident. But there is a faint grey line between male ego and a male surgeon's confidence. Many a times we keep flipping across this line repeatedly within the same day. So, what is that which changes us as testosterone, steaming testosterone filled male egoistic general surgeon to a pediatric surgeon who lets go of most of his ego and cares about this budding flowers of tomorrow? So, the easiest conclusion is that we handle children every day, and therefore we are much more humbler compared to many other surgical branches. This was also my answer when I was in training. Later, I stumbled upon a research which said that oxytocin is a hormone which is in high quantity in men who are in active role of taking care of their children. This is a hormone which is there in the women, which helps in ejection of milk during lactation. But the quantity is quite high even in men, as equivalent to women when they are taking active role in childcare. So I thought that since we are also taking care of the children, the oxytocin is probably the one which is making us more humbler and softer compared to very aggressive other departments, surgical departments. But later I stumbled upon my eureka moment. So, if you imagine pediatric surgery as a person, if you personify it and you personify this department as a woman, then it becomes clearer because this woman is teaching us to know the ways or the qualities of her. She's introducing us to her qualities, and through that, we are able to understand about children better. So here are some of the qualities of women that I would like to highlight and compare it to our department. The first is the balancing act. There are many women in professional role either travel from another city, their mother, their daughters, their wives, their daughter-in-laws and grandmothers, for various roles in the personal life and also various roles in the professional life which needs to be balanced. So in pediatric surgery, we also need to balance growth and development of the child along with the surgical condition. Let me explain with some few little simple examples. So, condition called hernia. So, usually many of you would be knowing the condition hernia. We have heard it in adults, but pediatric hernias are also quite common. But unlike adult hernias, the pediatric hernias are much more dangerous and it has to be operated then and there. So we find it in newborns commonly, especially if they are born preterm, and we have to do it before they get discharged from the hospital in the newborn period. Once they are getting graduated from the NICU and ready to go home, it has to be done because complications are much more in pediatric inguinal hernias than adult. Next is undescended testis. So in boys, the testis develops quite higher up close to the kidney, and during the development in the mother's womb, it comes to the normal position of scrotum. Sometimes this movement is not completed, and that is called as undescended testis. This has to be corrected within the first year of life. Else, the testis starts losing its function, and by the time the boy becomes an adult, many a times there can be even cancer developing in that abnormal testis. But if we correct it within the first birthday, the risk of the cancer decreases significantly, and also we will be able to preserve the function of the testis. So these each organ's growth and development has to be balanced, and the timing of surgery for each condition is very important. As pediatric surgeons, we operate from day 0 to 16 years of age. Whenever there is a illness in the child, the emotions run high in the family. The child himself or herself is very uncooperative to deal with when the child is suffering. So, having an empathy and understanding the condition from the child's perspective and the family's perspective is important. This is again not one size doesn't not one size will fit everyone. So the treatment will many a times be designed based on the child's condition, the severity of the condition, along with the parents' education level, their level of understanding, and their family structure. For example, there's a condition called anorectal malformation. This is a condition where the anal opening itself is not there. It is completely sealed off with thick skin. So there's no outlet for stools or poop to come out. And this is a congenital condition which is diagnosed at birth. On the day 1 of life itself, it is diagnosed. So there are various severities of this condition. Some children, even after it has been completely treated, may not have complete control on how they poop. They might still be passing small amounts repeatedly, soiling their underpants. So we'll have to train the parents on something called as washers, bowel washers. Similarly, there are conditions in boys called posterior urethral valve, which affects the outlet in the bladder, urinary bladder, and they also need to be on some kind of a regimen for getting the urine out. There are so many complex congenital conditions which require similar tailor-made treatments. There are some reconstruction which we do which are very specific to that boy and may not have been repeated to any other boy or girl. So this is what is understanding which goes in, and we cannot just force upon a treatment on anyone, because we need to be empathetic to the family and understand, because mother might be working, she might be a homemaker, the caregiver in the family, who is the caregiver, are they available with the child full time, if it is someone else, can they be trained? So all these understanding goes into the planning and treatment of pediatric surgical conditions. The third quality which is common between women and our department is that a leadership, community, and support. We have nurses who are specific for conditions like a colostomy. Colostomy is a bypass which is done where the stools are coming out from the abdominal skin, that is surgically made, and these are done for specific conditions, and the care of it needs to be taught to the parents. So we have nurses who are trained in this. There are nurses who deal with only burns injury. There are significant burns which can happen, more than 30%, 40% burns, and there are nurses who are for this, and all nurses are female nurses. From our department side also, as doctors, we interact with radiologists, pediatrician, anesthetist, and many other departments, obstetricians, gynecologists, even the laboratory services. So logistics when a child walks into the hospital, so that the waiting period is shorter, the period where the baby is kept fasting is shorter, the scans are done quickly, the blood is drawn in an effective manner. All these logistics, the surgeon takes a center role, and he is the nodal point for organizing all these things. So what are the specific conditions that we do? So here is an overall, is a basic overview for all of you to know. Our interaction with the family starts when the mother is pregnant itself. Many of the woman would have got an anomaly scan by around 4th or 5th month, and some of the times there might be some abnormality which is detected, and at that time the entire family is panicking as to how this has to be managed. Pediatric surgeons come into play there, and we counsel the family as to whether it is serious, does it require ending the pregnancy, can it be continued, if continued, what are the consequences, whether it can be treated, all these things, because majority up to 70% or 80% of the anomalies which are seen on the scan do not require termination. Many of them resolve by themselves, or even if it is there, doesn't cause any abnormality to the child. Only 20 to 25% of the anomalies require some treatment, and in that, again, a significant majority are completely treated without any hampering of growth and development of the baby. Only a few leave behind some residual disabilities. So, to sit with the family, a pediatric surgeon is required to counsel them through all these possibilities. In the newborns, simple things that we manage are hernia, hydrocele, branchial cyst is a swelling in the neck, which is one final treatment which doesn't require any major operation. It's a smaller surgery, and once it is done, there will again no ugly scars, no restriction in neck movements. These are all something very minor. Cystic hygroma, hemangioma, these are all the problems of the vessels, blood vessels, and the WBC flowing, the white blood cell flowing lymph vessels. These are again treated with sometimes with surgery, many a times with medicines, not even a surgery. Tongue tie. This is what, if not treated before the child starts speaking, will lead to abnormal speech and later will require speech therapy. But if we do it within first year, will not have any issues, and the surgery itself lasts hardly 5 minutes. Labial synechiae is another very commonly misdiagnosed. Many a times it has been said that the baby is, this is seen only in girls obviously, and they have been told that there is no vagina at all. The child is born without her genital organ, but actually it is only the skin which is just touching each other and closed, and all it requires is a simple separation of the skin and it opens up. And this is done in the OPD, not even in the operation theater. But before this procedure is done, the emotional trauma that the family goes through is tremendous, because they would have thought that the child is having no genital organ at all. Ballooning of foreskin in boys, undescended testis, which I've already mentioned. So these are all some of the very basic things. Complex things requires it means that some very significant urinary tract infections are associated with swelling in the kidney, the urinary bladder, or the tube carrying the urine, that is a ureter. Pediatric urology forms almost 60 to 70% of our work. We are pediatric surgeons along with pediatric urologists, pediatric oncologists, and pediatric surgical gastro. So, if there is jaundice in a baby more than 1 week of life, if you find that the child is having repeated bloating of the abdomen, repeated vomiting, especially green colored vomiting, bleeding in the poop or urine, these are all some of the conditions which you need to look for and visit a pediatric surgeon. Toddlers and in older children, cuts, falls, and injuries are quite common. Uh, Hypospadias repair again is a urological condition where the boy is passing urine from the under surface of his penis. The opening is abnormally located below, and it has to be repaired. But again, when we do this, the boy is not going to have any dysfunction in his sexual activities, and he will be able to be a father in the normal way. So, this counseling is required, and the message needs to go to the population. Severe constipation. Sometimes people are come to my clinic telling that they have abnormality in both urine and poop, so much so that they have been diagnosed elsewhere, telling that he has some disability in the nerves, so some brain issue or the spinal cord issue, but it is just severe constipation which has got been managed properly. Appendicitis, burns, these are all some of the things that we do. So this is a very broad overview of this beautiful department of pediatric surgery, where we manage with some corrective surgeries, a lot of reconstructive surgeries, so that the child's entire lifetime is preserved. There is least or absolutely no disabilities left. The growth and development of the child is as normal as possible. You can reach out to us at these numbers, or you can please drop in a mail if you have any queries, or you can scan the QR code. I'll end by showing you a small little video clip where a US based surgeon talks about this department very beautifully. He has summed up my talk in really beautiful lines. Thank you.
There is a saying that the two most important days of your life are the day that you were born and the day that you realized what you were born to do. So when I was an adult surgeon, I was much more ego-driven. I was about saving lives. But I realized when I started taking care of kids, it was about saving whole lifetimes. When you save a whole lifetime, no one remembers the little bitty things that happened that saved a lifetime. So you become insignificant. And it was that insignificance, that humility, that really led me to the humanity, if you will, of pediatric surgery.
Good morning, everyone. Good morning. We all set for our time out?
When we walk into the room, there's a lot of perfunctory and performative actions that occur before the patient gets to sleep. And the one thing that I use there to help me focus, for every patient, I always say when we do the consent, the timeout, that this is the world famous so-and-so. That is my own internal recognition that this is someone's child. And this is not the same hernia that I did the case before. And that it helps me recognize, and I hope it brings in the power of the room into the focus, that we're here for this one child at this one moment. The least of what I do as a surgeon is what I do with my hands. The most important things that I do is with my head, is how I compose the operation, how I understand the cadence, which for me is tempo, and tempo is procedure and pause. And so in my mind, I'm thinking of procedure and pause, tempo, cadence. And sometimes it's time to speed up. Sometimes it's almost important to kind of step back and see the entire field so you don't get tunnel vision. And then once the operation is complete, I try to make sure that, everything is in order. We did everything that we planned to do, and we wait to make sure that the child awakens appropriately, and I go out and I talk to the parents. That is where I think I do the second most important part of the case, or a part of who I am, which is parallel to the head. That's where I use my heart. And I recognize that at times, mothers in particular, but fathers in very hidden or subtle ways, are really anxious. How did things go? Sometimes things didn't go as well. And I have to use my heart as in a compassionate way to touch them, so that I can either bring them strength or bring them solace. And I hope she'll be able to go home tomorrow. We keep her overnight, make sure that she's not having any nausea and that her pain is controlled. You know how we are taking care of kids. We're probably a little bit more protective. And as great as we think we are, most parents want to forget that Ed Barksdale ever existed. And Ed Barksdale wants them to forget that he ever existed, because that meant that things went well. And Ed Barksdale wants them to forget that he ever existed, because that meant that things went well.